Okay, so this is environmental research seminar, and welcome to this seminar. And this seminar is sponsored by the Michigan Center on Life Stage Environmental Exposures and Disease, in short, M-LEEaD. I am Sungkyun Park, Associate Professor of Epidemiology and Environmental Health Sciences, and co-lead of the Integrated Health Science Core. I'm very pleased to introduce today's speaker, Dr. Liuhua Shi. Dr. Shi is Assistant Professor of Environmental Health, Rollins School of Public Health, Emory University. Dr. Shi received the BS and MS from Beijing Normal University and Doctor of Science from Harvard T.H. Chan School of Public Health. Dr. Shi's research focused on employing massive data sets, including satellite retrieved high-resolution exposures and health data to investigate how climate change and air pollution influence seniors' health. So today, Dr. Shi will talk about long-term air pollution and instant dementia in the United States. So please join me on welcoming Dr. Shi.
Thank you so much. Let me try to share my screen. Could you see my screen and could you hear me clearly?
Good.
That's great. Thank you for the introduction and thanks a lot for the invitation. Hi, everyone. This is Liuhua Shi. I'm really very happy and very honored to have this opportunity to talk about my work. I am an assistant professor in the environmental health department at Emory, and my work has been focusing on looking at the chronic effects of air pollution, climate change on elderly's health. Today, I will talk about the associations between long-term air pollution exposure and neurological disorders, particularly dementia in American older adults. This is a very interesting topic and definitely a new area of research. There is not a lot out there. Let's start by talking about why should we even think about the neurological effects of air pollution? Dementia is a public health priority with substantial economic and social burden. The most common type of dementia is Alzheimer's disease. And here show you some projections of Alzheimer's cases around the world. And these three figures show the situations in 1950, 2000, and 2050, respectively. We can clearly see that the number of cases has been going up dramatically. At present, we have about 50 million AD cases globally, and by 2050, it's getting huge. It's going to be tripled, about 150 million AD cases. In response to this devastating public health threat, the National Alzheimer's Project Act, NAPA, was signed into law to overcome Alzheimer's disease and related dementias. We also call it ADRD. And this national plan to address ADRD was launched, with the first goal aiming to prevent and effectively treat ADRD by 2025. Therefore, to identify and intervene on modifiable risk factors that could prevent or delay the onset of ADRD is a national priority. In addition to ADRD, Parkinson's disease PD is also a global public health issue. PD is the second most common neurodegenerative disease. And here, this figure shows that the prevalence of PD is high in North America, highest in Canada, and followed by the US and Argentina. In 2016, about 6 million people were diagnosed with PD globally, compared to 2.5 million in 1990. So the number of PD cases more than doubled in the past 30 years. even though the populations are aging. And on the other hand, we have these identified genetic risk factors, but aging and genetic risk factors really don't fully explain this increasing number of ADRD or PD. And recently, there is emerging evidence showing that there might be a link between air pollution, particularly PM2.5, and brain disease. So how do these particles get into our brain and have an effect there? There are several ways that PM can enter our human body and influence the brain. First, usually the particles are inhaled through the nose. And once they enter the nasal cavity, they can penetrate the brain directly. The other option is that the inhaled particles enter the body through the lungs, and then they can be absorbed into this bloodstream. And through the bloodstream, they can potentially cross the BBB, the blood-brain barrier, and reach the brain. Another way is that once these particles enter the lungs, they can cause inflammation, and there will be more pro-inflammatory cytokines produced. And these cytokines can enter the bloodstream and have a secondary effect on the brain. So not necessarily the particles themselves, but also the pro-inflammatory factors can enter the brain and have adverse effects there. So the neurological effects of air pollution, and particularly particles, is certainly something we need to worry about. In addition, air pollution, is highly prevalent, can influence a large group of population, and can be modifiable by those public policy with benefits at the population level. So it is quite important for us to look at whether air pollution might be a risk factor for neurological disorders. Some good news is that air quality in the US has been improved since the Clean Air Act in 1970. And we can clearly see that the national air pollutant concentration averages have decreased in the past few decades. And here, the purple line shows the national annual PM2.5 concentrations. So we can see that on average, the PM2.5 levels were well below this most recent national standard. And then you may wonder, does this low concentration PM2.5 well below the national standard still matter for our brain health? Therefore, we have proposed these scientific questions. First, is exposure to long-term air pollution, particularly from particles, associated with increased risks of ADRD or PD? And does low concentration air pollution, even below the current national standard, still matter? I started working on these projects since 2019 during my postdoc at Harvard. And I want to start talking a little bit on my postdoc work first. This work was published in the journal Lancet Planetary Health in 2020, and we focused on PM2.5 in that project. To quantify the neurological effects of PM2.5, here we are trying to use the big data approach. We have three components for the environmental epidemiology studies: exposure data, health outcomes, and statistical methods. As for the exposure, we used the satellite retrieved high-resolution daily 1 kilometer air pollution exposure data from an ensemble learning approach. As for the health data, we used the large-scale population-based Medicare data, which has individual-level information for about 70 million Medicare beneficiaries and approximately 500 million person years. Given this huge data set, you can imagine the computational challenge. So the traditional Cox model is not feasible for such massive data set anymore. Therefore, we improved the traditional statistical methods and also utilized the parallel computing techniques to accommodate such a massive dataset and improve the efficiency of the models. Let's take a deep dive into each of these. Instead of looking at a particular region, in this study, we are looking at the whole United States. And our study population are the national fee-for-service Medicare population who are older than 65 years old. We constructed an open cohort for all these 63 million fee-for-service Medicare beneficiaries. So that's about 1/5 of the entire US population. And in total, we have 480 million person years. So you can imagine that even fitting the statistical models can be quite challenging, and we will talk about that later. The health outcomes include the first hospital admissions for PD and the first hospital admissions for AD or dementia. So for the first cohort, we followed each Medicare beneficiary until the first admission with primary or secondary diagnosis codes for ADRD, or we follow these people until the death or the end of study. And similarly, we constructed a separate cohort for Parkinson disease. And all these hospital claims data were obtained from the MedPath file provided by the CMS, the Medical Center. And as for the exposure, we used the satellite retrieved high-resolution PM2.5 data predicted by my Harvard advisor, Dr. Joshua's lab. And we collected PM2.5 measurements from about 2,000 air quality monitors across the US. And we collected more than 170 predictor variables, including the meteorological variable, the satellite data, the land use terms, chemical transport model outputs, and so on. Then we fit 3 machine learning models respectively, including neural network, random forest, and gradient boosting. Eventually, we used an ensemble learning approach to combine the predictions from all these 3 machine learners and generate the final daily 1 kilometer PM2.5 dataset. We also did the tenfold cross-validation, and we found a moderate prediction performance. We can see from this map, the satellite retrieved PM2.5 data has full coverage. They cover both urban areas and rural areas, so we can have more low concentration PM2.5 data. And this nationwide daily 1 kilometer PM2.5 dataset have recently been published on NASA CDAC website, so they can be publicly accessible and available to the general public. In the very beginning, we tried to fit this large dataset using the traditional Cox model. But very soon we realized that it's not feasible at all for fitting a model for all these 408 million data records. Even though we do have good computational resources at Harvard, the memory size it requires is far beyond what we have. So then I collaborated with the biostatistician Dr. Xiao Wu at Harvard, and we solved this problem. The basic idea of our approach is to aggregate these individual level records to a high dimensional space of features. For example, if people, they have the same like sex, age, race, zip code, and so on, and then these people, they should belong to the same high dimensional grid cell because we don't need to treat them differently. We can safely aggregate these records into the same grid cell. So in this way, the data size can be significantly reduced. And in addition, we can fit log linear model for this aggregated, this grid cell dataset which we can also utilize the parallel computing techniques, which are not available in Cox model. So eventually, this approach, this Cox-equivalent log linear model, and combined with these parallel computing techniques, so we only need 2 hours for one model. So this is a big improvement. And more specifically, here shows you the stratified, the Cox-equivalent log linear model to estimate our exposure and the hospitalizations. The outcome variable was the number of first hospitalizations aggregated in each high dimension grade as shown here. So that is the number of first hospitalizations in each grade. And each grade indicates the same follow-up year, same calendar year, same zip code, same age, sex, race, medical eligibility, the same individual level information. So each grade, that means that stratum. And in the model, the offset term is the corresponding person years, person time for each high dimensional grade. So that is for each grade, what is the corresponding the total person years? And to allow each stratum, they have different baseline hazard. We stratified our model on individual these characteristics, and we also adjusted for the neighborhood, socioeconomic status, these behavioral risk factors like BMI and smoking, and we additionally accounted for this residual confounding by spatial and temporal trends. We also proved that mathematically, this log linear model can be equivalent to the Cox model, and we wouldn't lose any information. More details can be found in the supplementary materials of our paper, and I won't go into the details here. And the Cox models treat all observations as independent. To account for potential spatial dependency in these observations, for example, people living in the same neighborhood, let's say people living in the same zip code, living closer to each other, these people, they are more likely to be at similar health risks. So the observations are not entirely independent. They actually have some spatial patterns. So to account for these spatial patterns of the observations, we performed the M-LEEaD bootstrapping to obtain more robust standard error and confidence intervals. So each time, we did the bootstrapping, we did like 500 bootstrapping. And for each bootstrap, we randomly sampled M zip codes out of the total N zip codes. And we repeated that 500 times. And in the end, we calculated the standard error for those 500 bootstrapped effect estimates. So in this way, these standard error, they're more robust because we have already break down the potential spatial dependency between those zip codes. Okay, and here shows you the results. We identified 3.4 million these ADRD cases and 1 million PD cases. And we found that both endpoints, they were associated with long-term exposure to PM2.5. Per 5 microgram per cubic meter increase in annual mean PM2.5. The hazard ratios were 1.13 for both ADRD and PD. What is more interesting is that the low exposure analysis, when we restrict analysis to the subjects who were always exposed to low level PM2.5 levels, below 12 microgram per cubic meter, for this analysis, it yielded even larger effect estimates, and with a hazard ratio of 1.18 for ADRD and 1.14 for PD. So the take-home message is that PM2.5 is not safe, even below current national standards. We also looked at the dose-response relationship for PM2.5 and neurological disorders by fitting the penalized splines. And here shows the results for both endpoints. we found that the association was almost linear, below 16 microgram per cubic meter. And we have 95% of our data set are within this range, below 16. And above 16, we observed a plateau association, and then the curve go wildly at high PM levels. This indicates that these flexible penalized splines, they are kind of sensitive to these potential outliers with high leverage. This is the first nationwide US study on air pollution and neurodegeneration. However, there are several key limitations of this study. I think the key limitation is that we were using the hospitalization records, which cannot represent the disease incidence. Like AD, dementia, they have long insidious onsets, and we don't know the exact timing of disease onset. So we won't be able to look at disease onset using the administrative cohort. And for these and hospitalization records, they are usually capture more severe cases, but the earlier disease diagnosis, they are more likely occurs at doctor visits instead of during hospitalization. So using hospitalization records, we likely missed many cases. To overcome this key limitation, using the hospitalizations, and since I joined Emory about 2 years ago, I have acquired a new medical data set. It is called the medical CCW data set, which includes more comprehensive claims records. It includes the predefined indicators for both dementia and Alzheimer's disease based on more claims records from more sources, such as the medical inpatient claims, the outpatient claims, doctor visits, skilled nursing facility, and home healthcare claims. So we have more claims from different sources instead of only relying on the inpatient claims, the hospitalization records. So using these new health records, I have been collaborating with my colleague, Dr. Castellan, and also other collaborators to look at the association between long-term exposure to air pollution and incident dementia in the nationwide medical population. And this paper has been recently published by Nature Communications. Because we have a lot of medical beneficiaries, we have ample power, and we used a more conservative criteria for the study population selection in this new study. We restricted the study to the medical population in the US who are older than 65 years old and who were always enrolled, has a continuous enrollment in Medicare fee-for-service program in both Medicare Part A and Part B programs. Without these restrictions, we might miss those dementia diagnoses for the study subjects. For example, if we included subjects who were only enrolled in Part A, that means we will only have their hospitalization records, and we'll miss his diagnosis occurring in Part B, like diagnosis occurred during doctor visits or during outpatient visits. And we further required a 5-year clean period. That means the subjects need to be dementia-free, so no diagnosis of dementia in the first 5 years after enrollment. This will help us to increase the possibility to really capture his first diagnosis of dementia or AD, and therefore we could better approximate the disease incidence. So in this way, we constructed the cohorts for both dementia and AD respectively. We follow each person until the first diagnosis of dementia across all those claims, or the first diagnosis of AD across all those claims. And we identified about 2 million dementia cases and 0.8 million AD cases out of the 12 million study population. And as for the exposure, we used the high-resolution air pollution data introduced before. Based on these daily 1 kilometer predictions, and we calculated the zip code level annual means for PM2.5 and NO2, as well as the warm season mean ozone for each year from 2000 to 2016. We used the warm season ozone here because ozone is a highly temperature dependent and it is more readily formed in the warm season. So it is only a concern in warm season. And this metric is often used in long-term ozone-related EPI studies. Then for each subject, we further calculated the 5-year moving averages for PM2.5, NO2, and warm season ozone based on their residential history. And this PM2.5 ozone, this high resolution data set have already all been published on NASA ScD. We fit single pollutant, bipollutant, tripollutant Cox models and estimated these hazard ratios per IQR increase in the 5-year average of this annual PM2.5, NO2, and warm season ozone in the past 5 years. And we also allowed for the strata-specific baseline hazard functions. And we adjusted for this neighborhood socioeconomic status, behavioral risk factors, and we additionally adjusted for this healthcare capacity. And also we accounted for the residual confounding by spatial and temporal trends. And here shows you the results. No matter single pollutant or multi-pollutant Cox models, we always observed elevated hazard ratios for both dementia and AD in relation to PM and also NO2. The effect estimates were strongest for PM2.5. However, the hazard ratios for warm season ozone were not elevated, and probably due to the collinearity, the results for ozone were not consistent here. We also looked at the dose-response relationship by fitting penalized splines. Here shows the curves for all 3 pollutants derived from the tripollutant models. And this is more obvious. We observed a very strong signal between the PM2.5 and both dementia and AD among all pollutants. And the concentration response relationship were approximately linear for NO2. For NO2 at lower NO2 levels, like below 25 ppb, and then it kind of level off for higher NO2 concentrations. For ozone, the curves were essentially flat for both endpoints until at very high concentrations where few data points occurred here. We also examined like 5 potential effect modifiers for PM2.5 and NO2, because given the observed associations between them and the both endpoints. And we found, we indeed observed some health disparities here. We found that the Black, the people with lower SES, and residents who live in the urban areas, they are generally at higher risks of, AD dementia here. And we did a lot of sensitivity analysis, and our results were quite robust. Our results support our main findings that long-term exposure to PM2.5 and NO2, and not ozone, were significantly associated with the increased risks of dementia and Alzheimer's disease. In the sensitivity analysis, we used a more strict clean period of 10 years. So we require that the people needs to be dementia-free in the first 10 years of follow-up. So we can more confident that we were really capturing the first diagnosis of ADRD in their lifetime. We also assessed alternative exposure windows. And we adjusted for comorbidities. And we also assessed the effect of possible outcome misclassification. because we were concerned about the outcome misclassification, so we tried different ways to do that. First, we tried to feed some linear regression models for the rate of dementia, or AD, because the literature said that in linear model, the random misclassification of the outcome would tend to be absorbed into residual errors of the linear model for the true counts. So outcome misclassification might be less of a concern. And here shows you the results. The linear rate model, we found that the hazard ratio is a little bit higher than the traditional Cox model. So it indicates that we will likely underestimate the true hazard ratio. And in addition, we also tried to use the sensitivity and specificity for the outcome misclassification from previous literature, the Taylor paper. And we corrected for the number of case counts for each zip code. And we fit a stratified Cox-equivalent Poisson model. And here shows you the results. And both sensitivity analysis showed that if the outcome misclassification is non-differential, and we were likely underestimate the true hazard ratio. So I have showed you the current analysis where we observed an association between PM2.5, NO2, and ADRD. Our next move is that first, we want to see whether the observed association may imply a cause link. So we're planning to perform some cause inference approach to assess the causality. Second, we know that PM2.5 is a mixture of different components, different substances. So is it one particular substance, one particular component like black carbon or some metal, they might be most toxic? And we think this question is very important for policymaking, and we need more research. And here shows you some preliminary results. We used the PM2.5 major components data provided by Dr. Randall Martin. And we found that the black carbon and the sulfate seems to be most neurotoxic. But we are not so sure about how to interpret the results for sulfate, whether the sulfate is toxic by itself or whether it only provides a more acidic environment for the metals. So more metal elements or particles get absorbed and harm the brain. I don't know, we need to do more research. So that's why we are going to collaborate with Dr. Josh Watts, who has just finished predicting the high resolution 1 kilometer PM2.5 components, for 15 components, including metals, across the US from 2000 to 2019. And we are going to conduct some mixture analysis like WQS or maybe BKMR to identify which components that are most responsible for the increased dementia and AD hazard we observe. Yeah. Lastly, I would like to acknowledge all my co-authors and collaborators. Thanks a lot for listening.
Great talk. Thank you very much, Dr. Shi. Maybe you can just still share your slide, and we have a couple of questions. Dr. Shi, so let me read the question for those who cannot see that question. So I will read this, and then, but you can also take a look if you can open the question Q&A box or chat, and you can directly read that question. So we have a question from Dr. Sarah Adar. So thank you so much for the very interesting talk. In your new cohort study, I wonder if you worry about the introduction of selection bias by requiring that individuals must survive for 5 years before being included in your model, since air pollution is related to survival. So perhaps this might explain your over 75 results. So can you answer that?
Yeah, thank you for the comment. I think this is a very good point. Yeah, indeed, we use a very conservative criteria to select study population. So indeed, we were worried about the selection bias. Yeah, so that's why we further conducted some sensitivity analysis by requiring like two years of clean period or 3 years clean period. And we found that the results are quite robust. Yeah.
Okay. And then the second question also relates to this age difference. And so for the effect modification of age, is there any explanation about why younger population age less than 65 have higher hazard ratio than the older?
Yeah, thank you for the question. So we're not so sure about whether our posits are correct or not, but we think that one possible reason is that the relatively younger population, like between 65 to 75, they are more likely to go outside. So they are likely more exposed to those like traffic related pollution or some other source of pollution, the ambient pollution. And likely those source like pollution, they are more like, they have more like neurotoxic components like the metals or black carbon. So for the relatively older population who are older than 75, they're more likely staying at home. So they're less likely to be exposed to those like traffic pollution or some other source of ambient pollution.
Great. So we have two other questions from the chat. So you can also open the chat. So by Trishi Komen, who asked about excellent presentation. I am interested in how exposures during certain periods of development might have lifelong impact. How do you control for earlier life exposure to lead, for leaded gas, pain? That is likely to be highly correlated with PM even today.
Yeah, that's a very good point. So here in this study, in our meta-analysis, we used the average pollution levels in the past 5 years as the main exposure period. And when we did the sensitivity analysis, we considered both more recent years of exposure and also the exposure in a longer time period in the past, like 10 years ago, 5 years ago, 6 years ago, and in the recent like 1 year, in the current year. And here's what we found. We found that shorter exposure window, like more recent years, the current year, the annual mean PM2.5 and O2, we observed that the shorter exposure window, they yielded a larger health effect estimates. So this is a little bit different from what we expected because we thought that air pollution levels maybe like 10 years ago or in the past 10 years or in the past 10 years, they were more likely, be more relevant to the dementia because given that the dementia is really, has a very long insidious onset. So that's why we did the sensitivity analysis. But we found that the shorter exposure window in our analysis, they yielded larger effect estimates. So this indicates that air pollution, it may not only relevant to the dementia, initiation, the development, it might also contribute much to the disease progression, even though the disease is already, even though dementia is already well developed. So air pollution, more recent years air pollution, they can still contribute to accelerating the disease progression. So this is one thing. And the other thing is that we believe that, earlier life exposure, as you mentioned, earlier life exposure to lead or some other sources, they might also, be correlated to PM today. But in our analysis, we had no way to account for that yet. Yeah. So that's the limitation of our analysis. Yeah. Thank you for the comment.
Okay, so another question from the chat. Thank you for the amazing talk. In regard to the effect of I guess a sulfur component in PM2.5. So where there are any study investigating the effects of SO2, sulfur dioxide, on dementia and AD, or is data on SO2 in the US available?
I think, let me see. I don't see much evidence on, like SO2 on dementia yet. Yeah. I think the data, I think there are some monitoring data on that, but really in the US currently, the data set for, for pollutants other than those like PM10, PM2.5, those more common pollutants, they are really very limited monitor size to measure those like SO2 or other pollutants. Like for Dr. Joe Schwartz, like PM component prediction, we in total collected about 800 monitor measurements across the US in the past 20 years.
So in the future you will have more this PM component, but not necessarily SO2 specifically, right?
Yeah, not necessarily SO2, yeah.
Okay. All right, so we have another follow-up question by Sarah Adar. So it is very nice that you consider the impact of misclassification of the outcome, since you are using administrative record that depends on people seeking care to be diagnosed with these outcomes. You mentioned that you evaluated non-differential misclassification, but I wonder if you consider the possibility that the errors are differential, since SES may track with both air pollution and different pursuit of medical treatment.
Yeah, so this is what we acknowledged in our paper in the limitation, in the discussion section. So our sensitivity analysis, we assumed the non-differential outcome misclassification because we didn't, because there are no data showing that they are differential. So, but indeed, it is still likely that the outcome misclassification is differential. And I think we need to, conduct more research, our future research, to explore more on that aspect.
So can I say something about that question?
Yeah, sure.
Just that if people with low SES don't seek medical treatment, then they may not be in the cohort. I'm a little lost. I'm not sure that people who are in Medicare and are getting medical treatment would be less likely to be diagnosed with AD, which I think is what you're suggesting here with differential.
Yeah, so this is my this is my colleague, Dr. Castillo, who was the co-first author of our paper. So I invite you to help me address some questions from the audience.
Okay. All right. We have another question by Dr. Marie O'Neill. So thank you for a great talk. Do you have any plans to do similar studies in other parts of the world where air pollution levels are much higher and you will have greater precision in your estimate at the upper range of exposures? So it may be that acquiring big data is more challenging in such setting.
Yeah, so we do think that it would be very interesting, to also explore this kind of question, like in China or in India, where pollution levels are extremely high, are very high. But the health data collection is really very challenging in those countries, and we don't have very good dementia, Alzheimer's disease, health data yet. But indeed, we have been collecting those air pollution data set and do the machine learning exposure modeling. So yeah, I think our next plan is to maybe talk to those collaborators in China or in India and see whether they can collaborate with us by providing us some very good dementia diagnosis data.
Good. So we have additional question from the chat, and let's see. So the Howran, I cannot see the entire last name, but Thank you so much, Dr. Shi, for the nice talk. This is amazing. So for your next move on causal inference, will you look into the biological mechanism or the toxicity at the molecular level to further illustrate how PM may give rise to or exacerbate AD and PD? Most modern causal inference approaches from social science or data science do not involve molecular mechanisms and are just statistical in nature. So how do we make up for that?
Yeah, so my lab has been, so our work has been focusing on using, this population-based health data set to conduct the statistical analysis. And indeed, I think it will be more interesting if we can, look at those biological mechanisms or the toxicity at the molecular level. And we do have some colleagues who have been working on that. And I would love to collaborate with them to explore the question at the molecular level. Yeah, but at this stage, my lab has been focusing on statistical aspects.
Yeah, actually, this is a very interesting and a challenging question because as an epidemiologist, we try this causal inference, but so it's not like a toxicological design, but there are several ways to test this causal relationship and then evaluating this mechanism. So although it is different from toxicological experimental study design. Okay, so another looks like this is just comment, but by Steve Goodman. To follow up on Dr. Adar's question, so there could be further misclassification based on SES, where based on access to care, some may assume a diagnosis of AD, where it is actually a different dementia subtype.
Yeah, that's very interesting. Yeah, so I think, so our current analysis has not accounted for that part yet, but I do think in the, in the future, we need to, think more about, the misclassification and those whether AD is a different dementia subtype. Yeah, and thanks so much for the comment.
So we have a little more time. So if you,
I would just like to comment on that last thing. We found the same kind of effects for dementia as we did for AD. So the broad category of dementia, which would include the various subtypes. So I'm not sure that our findings are not specific to AD.
Okay, and then, actually there's one very interesting, so is air pollution a cause or a risk factor?
Yeah, so, we have been conducting these observational studies, running Cox models or Cox-equivalent linear models. So we will interpret our results very cautiously. We observed associations between air pollution and ADRD. At this stage, we cannot interpret our results causation. We need to conduct more rigorous, cause inference approach, difference in difference, weighting, matching, if we can obtain very consistent results, showing the link between air pollution and ADRD using different cause inference approach under different cause inference assumptions, if we still observe a very consistent link, and then maybe we can say air pollution may cause ADRD. But at this stage, I won't interpret our results as, causation.
Okay, so actually I want to end this talk with the question that I have. So you showed in your first paper the stratified by less than 12 microgram per cubic meter, and then greater than that level, and then you see the higher exposure level, and the 12 is that is current national ambient air quality standard. And then right now the EPA is considering revising that level. So can you make some comment about so what would be that standard to reduce the level, reduce the risk of this AD and dementia? and more realistic level that we need to make sure. Okay. Do you have any idea about this national ambient air quality level that you can propose?
Oh, you mean the revised the NAAQS level for PM? Wow, that's a very hard question. Yeah, so as I show here, so if we are looking at like dementia and AD, so our results will really, see a very, a approximately linear association, right, between PM and ADRD in both studies, whether looking at hospitalizations or disease incidence. So we don't see a threshold for PM, we don't see a threshold for that. So I think, yeah, it's hard for me to give you, an estimate what is the best NAAQS standard. I can only say that we didn't see a threshold. So even low-level air pollution is still harmful. So I think we need more evidence from, also for other endpoints and see whether other endpoints, they propose any threshold for PM.
Okay, thank you, Dr. Shi, for your, this is an excellent, presentation and then a long Q&A, and then we receive a lot of these interesting comments and questions, and then you address this question very well. So thank you for attending this seminar. So we will have another seminar, and then please stay tuned, and then we will announce the next seminar in the future. Thank you.
Thank you so much for the invitation, and thanks a lot to everyone for your attention. Yay, bye.